Let's start with the U.S. We have already seen 11 deaths out of only confirmed 120 plus cases or so. Does that make sense to you?
It makes sense in the sense that we can find those people who are sick. We're actually not finding people who are not sick. We're only finding the sick ones. And so, and we're finding them in nursing homes and other places where the death rate is likely to be higher. So I think the enrichment for death over infection is artificial. There are many, many people who are infected who are not detecting. And that's a direct result of our not having tests available. Even today, as we speak, as you and I are speaking, those tests that are widely available all throughout China, many millions of them have been tested. We just don't have yet.
Now we're getting more and more news of the virus spreading in the U.S., or at least more confirmations of the spread. Facebook now coming out and saying that an employee in Seattle has been diagnosed with the coronavirus. Facebook now the latest in the number of businesses affected by this virus outbreak. We have seen this type of virus before. Why don't we have a solution to this?
It has to do with human nature. We respond to crises and then we forget, and we are absorbed by the next crisis that comes along. I'm not the only one who's been warning that nature is there ready to pounce. We know about volcanoes, we know about earthquakes. If you live in an earthquake zone, you make preparations to make buildings earthquake proof. We live in a world where the natural world of viruses will continually assault us. We know that. Yet we haven't taken the most fundamental precautions. And in particular for this type of virus, nature has warned us twice with the SARS epidemic and the MERS epidemic. It's warned us twice that these are dangerous viruses. And if you think a little bit beyond that, we've known that these viruses are around for a long time. Every season, there's another coronavirus that comes through and gives us a cold. Well, think about this. Polio was a cold virus with an unfortunate habit that it paralyzed about 1 out of 100 people who got it. It's very similar to the coronavirus. It may kill 1 out of 100 people who have it. The symptoms are a little bit nastier than a cold for about 15% of the people. But that's the natural world, and we know and we have the tools to prevent it. We can develop drugs that could be stockpiled and available to prevent transmission. Just like we know how to prevent AIDS transmission now. We could prevent flu transmission, we could prevent coronavirus transmission, and others, and we should have done it, but we didn't. Hopefully, we'll do it now, although I'm not at all sure that we will.
But with HIV infection, obviously huge strides have been made since the introduction of PrEP, right?
Right.
Could something similar be done for various strains of coronavirus?
Well, you know what's great about it is if we find the right combination of drugs, and it usually takes a combination of drugs, more than one. If we find the right combination of drugs, it should work on almost, if not all, coronaviruses. The combination of drugs we use to treat HIV work on almost all strains of HIV. So the techniques the virus has to evade our immune system don't work so well to evade our drugs because we work not on the outside of the virus with the drugs, we work on the inside, and the inside stays much more constant than the outside, which changes to thwart our immune system.
Let me go back a step. You were talking earlier about the very limited nature of testing that's taking place in the US, right? We know that's why there's differences between the confirmed cases we see in South Korea, for example, versus Japan, because of the huge gap in how much each of these countries is capable of testing. If you don't test broadly, how much of a risk is that for allowing big gaps when it comes to community transmission?
It's enormous. The way we know in public health how to handle these kinds of things. You find one case, you test all of their contacts. If there's one case on a plane, you test everybody on the plane, and you test everybody who's in the family and has been in contact with that person. It's called contact tracing. To do that, you need to have the tests available. You need to have widely available, and you need to have a lot of them available. You don't want people to slip through your cracks.
How do you feel about Congress approving that $7.8 billion in order to deal with this outbreak?
It's a good start, and I hope
Where
it's put
should
to
it be
good use.
used?
It should be used first of all, for tests. It should be used for providing ventilators to hospitals. It should be used for making whatever medical supplies we need, and there's a lot of disposable supplies. If you go into a hospital today, you go into an isolation ward, everything you touch is disposable. Just even for ordinary surgery in a good hospital, everything's disposable. Well, you run very short of those very quickly in a crisis, so we need to prepare for that as well. Then there are longer range things we should do. We should begin to activate, we have legislation dating back to the anthrax attack, where people got really worried. We passed some very interesting laws and rules and regulations, and we follow those up with something called BARDA. So there's BioShield and BARDA, which gives our government the authority to fund and test and approve on a vastly accelerated rate new vaccines and new drugs. And so we need to include the coronavirus in the BARDA BioShield legislation. I developed a drug from idea to approval and stockpiling within 2 years and 2 months, or 2 years and 6 weeks. That sounds like a long time, but it's a lot shorter than 20 years, which it usually takes. And that's thanks to the fact that as a biotech company, we knew that the government would buy our product and stockpile it. And in fact, over the years, they spent $500 million stockpiling this particular way to protect against anthrax. So should there be another anthrax attack, our government has the drugs at its disposal to protect people exposed from getting sick and those who are infected from dying. That's what we should have had for the coronavirus, and that's what we should also have for flu. So I would think at least part of that money should go to that kind of development program, because this will not be the last coronavirus we get.
Bill, how do you rate the Chinese response in terms of the lockdown and containment measures? And is it fair that there's criticism that other countries around the world have wasted that window of opportunity that was given by China to get their own houses sorted?
Yeah, I don't want to make any judgment about another country. I'm comfortable talking about my own. And in that respect, I'm unhappy that we have not taken full use of the time we've had between the time we knew this was likely to be a threat and the time we've finally begun to mobilize some sort of response. But even now, our response is disjointed, it's not well coordinated, and it's not what it should be. You know, I was watching one of your rivals' programs just yesterday, and there was a doctor from a hospital just down the street who was basically tearing his hair out because he couldn't get access to tests for the people who came in to see him who were ill, and certainly didn't have access to treat any of their contacts. So it was it really was moving to hear this doctor sort of screaming in agony because he couldn't do his job, because we hadn't given him the tools needed to do his job. And he kept saying, look, we've known about this thing since December. And what do I have in my hands today? Nothing. It was really a moving performance.